Hi, my name is Dr. Mirielle Aujero. I'm a breast imaging radiologist at Delaware Imaging Network. It is my pleasure to speak with you today about breast cancer screening for at-risk women. I have no disclosures. In this talk, I will speak with you about the current screening guidelines, both from the American Cancer Society as well as from the American College of Radiology. I want to mention this past year, the American Society of Breast Surgeons updated their screening guidelines to now recommend screening mammography in women beginning at the age of 40. I'll also speak with you about risk assessment models to identify women at risk. I'll discuss breast density as an independent risk factor, and I'll discuss racial disparity in breast cancer. Female breast cancers represent 15.3% of all new cancers in the US. Last year, the American Cancer Society estimated upwards of 276,000 new cases of invasive breast cancer and expected over 42,000 women to die from breast cancer. Fortunately, breast cancer is treatable and in some cases curable when detected early enough, and we have made significant headway into the disease. This is a mortality chart over time. And on the x-axis, we have the years from 1980 to 2013. On the y-axis, we have the mortality rate per 100,000 population. The red line depicts Delaware females and the purple line, US females that are dying from breast cancer. And as you can see, in the 1990s, that's right about this time point, we implemented screening mammography. And as screening mammography became widely available, the mortality rate started sloping downward to decrease by 38% in 2013. When you see a patient in your office, how do you determine which one should undergo genetic testing? In our office, we follow the NCCN guidelines. That's this wordy table on the right, which I will not go over each of these individually, but you can definitely download this in your office to have it handy for when you evaluate a patient for the risk. If a patient carries a risk greater than 10% of carrying a BRCA mutation, we recommend that they undergo genetic testing. Almost 25% of women with breast cancer have family history of breast cancer, and women with an affected first-degree relative have a 1.75-fold higher risk of developing cancer. That risk increases to 2.5 when 2 or more affected first-degree relatives are there. Now, multiple genes have been identified that are associated with breast cancer. The more common ones are BRCA1 and BRCA2, and they've received a lot of attention because they're linked to 20 to 25% of the hereditary breast cancers. But now genetic testing has expanded to include 28 more genes. Now, you probably have heard of the 23andMe widely publicized test online that you can get from an online subscription, but it is important to know that this 23andMe only tests for BRCA1 and BRCA2 gene. So if the patient has a BRCA gene mutation, you can apply one or all 3 of these risk reduction strategies, being chemoprevention, prophylactic mastectomy, or intensive screening. Now, by intensive screening, this means yearly MRI or screening breast ultrasound if the patient can't get or can't tolerate MRI, as well as mammogram. Now, also when you see a patient, you will ask them for their family history. You can fill out some of the risk assessment models that are available online. A lot of these models are confusing, and when you do a search, you find many models available. And a lot of these models are not applicable to all the patients, so may not be applicable to your patient. But they do serve a purpose, and that is to give us a stratification on the patient's risk, whether it's a low risk, meaning less than 15%, or we would also consider that average risk, or if it's moderate risk between 15 and 19%, or if the patient has a high risk for developing breast cancer and they fall under the greater than 20 to 25% risk. So it is important to get that risk assessment so that we can implement a good screening strategy for them. However, these models should not be used to consider a woman ineligible for screening because about 85% of breast cancers occur in women who have no family history of breast cancer. Now, this table here, it's a little busy, but on this column here, we have risk factors. This is one of the models that is widely used as the Gale model. Then there's the BRCA Pro, the breast and ovarian model here, Bodicea, and the IBIS or Tyrer-Cuzick model. And these are all the risk factors that you can input into the model to spit out a risk assessment. And as you can see, the Tyrer-Cuzick is the most comprehensive of all models, including even breast density to increase its accuracy on the newest version, that's version 8. And it includes first and second degree relatives as well as male breast cancer. One study showed that the IBIS model, that's this model over here, was more accurate for assessing breast cancer risk based on family history than the Gale model, which specifically now, since the Tyrer-Cuzick model includes breast density in its calculation. At our office, every woman that presents for a screening mammogram fills out a questionnaire, and this information is used to get a risk. And what we use the Tyrer-Cuzick, the newest version, including the breast density. We use this model to get their risk. And this is printed out in their report. You can also put risk factors into 3 separate buckets. The personal hormonal bucket over here, you can use these 3 models for that. Or if the patient has had breast disease like LCIS, ALH, has had many breast biopsies, and including breast density, you can put them in the Tyrer-Cuzick. You can use the Tyrer-Cuzick model for these patients. If you're looking for hereditary risk factors, or you're looking to see if the patient has a hereditary risk of carrying a mutation, you can use these models over here. Mammographic density was also added to the Gale model recently, also improving its accuracy. Now, in some near future, we will be using artificial intelligence to better stratify patients' risk. Over here, we have a mammogram. This is a breast mammogram, and on the white here is the breast density. The darker areas are the fatty tissue. This is a system analyzing the density of the breast and the location in the breast. This one over here, the upper outer area, and this being the central breast area, that's depicted over here. The system analyzes this and evaluates the complexity of the breast heterogeneity within the patient. The more complex a breast, the higher the risk of this patient developing breast cancer. So in some near future, we will be using radiomics to analyze the patient's risk, in addition, of course, to the risk assessment models. Another thing coming up is SNPs, or single nucleotide polymorphisms. It is a single letter difference in the DNA, and everybody has SNPs. And each DNA, of course, encodes a protein or an enzyme. So these differences were analyzed in patients with breast cancer and compared to those without breast cancer. And these group of researchers identified 80 new SNPs that were associated with breast, prostate, or ovarian cancer. So in some near future, we will be analyzing patients' DNA to get an overall risk and get a better idea of the risk to develop breast cancer, depending on how many SNPs they have. Okay, now I'm going to talk about the guidelines for screening. These are the American Cancer Society guidelines. When the ACS guidelines came out in 2007, they stratified a woman into 3 risk categories: average, moderate, and high risk. For the women at high risk, there's little debate that MRI is recommended annually and that they have a lifetime risk of developing breast cancer that is greater than 20%. On this category are the risk mutations, BRCA, ATM, PTEN, and other high-risk mutations. BRCA itself carries an over 80% lifetime risk of developing breast cancer, so these women do opt to get prophylactic mastectomy and chemoprevention. In the moderate risk category, we have the women with dense breast tissue or with atypical cells like LCIS, ADH, ALH at the time of biopsy. Now, the American Cancer Society cited insufficient evidence to recommend for or against MRI. Again, I remind you this was in 2007. Recently, the American College of Radiology, as well as the American Society of Breast Surgeons, have put out new recommendations to include this moderate risk group and to stratify them and give them a better screening option. Here is the American College of Radiology put out their white paper in 2018 recommending that all women, especially Black women and those of Ashkenazi Jewish descent, should be evaluated for breast cancer risk no later than age 30 so that those at higher risk can be identified and can benefit from supplemental screening. This, until then, we had not identified Black women as having an elevated risk for breast cancer. The American College of Radiology also recommends that women at high risk or that fall in the greater than 25%, 20 to 25% group of lifetime risk for breast cancer, that they get an MRI yearly starting at age 25 and an annual mammogram starting at age 30. The exception is BRCA1 carriers who can delay starting mammography until the age of 40 if they had yearly MRIs starting at age 25. The reasoning behind this is at such young age, one has more dense breast tissue, and this is to limit their radiation. Now, for women with history of mantle chest radiation or who received a cumulative dose of greater than 10 gray before the age of 30, the ACR recommends yearly screening MRI starting at age 25 or 8 years after radiation therapy, whichever is later, and annual screening mammogram starting at age 25. Now, since the advent of 3D, we recommend 3D whenever possible. For the women who are at moderate risk, those falling between 15 to 19% risk, or those women can benefit from MRI as well, especially if they have dense breast tissue. For women who have had a diagnosis of breast cancer or atypical ductal hyperplasia or lobular neoplasia before the age of 40, annual screening MRI should begin at the time of diagnosis. So for example, if you have a 30-year-old patient and they come in with a palpable, calcifications were incidentally seen and biopsied, and it came back as a typical ductal hyperplasia, then that woman should undergo annual screening mammogram from then on. For women with breast cancer and dense breast tissue or those diagnosed before the age of 50, annual MRI is recommended. And for women with a personal history of breast cancer not included above or with LCIS, ADH, ALH on prior biopsy, MRI should be considered, especially if other risk factors are present. Now, we have talked about high risk and moderate risk women. And what about average risk women that have dense breast tissue? In previous, let me talk about this here. Okay. So there are 4 different breast categories that we report on our screening mammogram reports. On this side here, we have an entirely fatty breast. That's the dark areas is fat, and the white areas are glandular tissue. Here's a scattered categorized breast, and here's heterogeneously dense. As you can see, the density of the breast is higher, and here's an extremely dense breast tissue with extremely dense breast or a lot of glandular tissue in the white. Now, 50% of all women will fall here, and 50% of all screenings will fall in the extremely, in the dense category. Now, the sensitivity of mammogram decreases significantly the denser the breast. So for an extremely dense breast, the sensitivity can be as low as 50%. What does this mean? This means that In dense breast tissue, even a larger cancer is difficult to detect, whereas in the fatty breast, a small cancer is easily seen. So, women with dense breasts are 2 times more likely than the average woman to develop breast cancer, making density at least a moderate risk factor for breast cancer that is more important than traditional risk factors. Even when breast cancer is detected at screening, women with dense tissue have cancers that are larger, more likely lymph node positive, and of higher stage than women without dense tissue. So cancers in women with dense breasts are also more often multifocal or multicentric, needing more often a mastectomy than a lumpectomy. So masking of cancer by dense tissue has become a political issue which began in 2009. By now, we're probably all familiar with the advocacy efforts spearheaded by women diagnosed with breast cancer after receiving a negative mammogram. One such woman is Dr. Nancy Capello, who had her breast cancer diagnosed a few months after a negative mammogram. Unfortunately, at the time of her diagnosis, her cancer had already spread to her lymph nodes, and sadly, she recently passed away from her disease. However, she spearheaded the density notification law in Connecticut that enforced all sites performing screening mammograms to inform patients of their breast density so that they can be well informed and seek supplemental screening if desired. This movement has resulted in 37 state laws requiring some level of density notification following a mammogram. The level of information required to be given to the patient varies from state to state, with some states requiring a patient receive only general notification, while others require a woman be told if her breasts are dense. Many states with these laws are also require that women with dense breasts be told that they may benefit from supplemental imaging tests such as ultrasound or MRI, and many of these states require insurance coverage for these supplemental screening. Unfortunately, Delaware is not one of those states, so I know that it can be a real pain to get some of these women's insurance to cover their MRI, or in some cases even to cover their screening breast ultrasound. And radiologists nationwide recognize this need, and several facilities, including ours, have implemented a screening MRI protocol that's been abbreviated from the regular protocol that we can make available to patients whose insurance does not cover screening MRI, and half dense breast tissue and one disc supplemental screening, and we can give it to them at a low, affordable, out-of-pocket cost. My colleague, Dr. Holt, will speak to you more about screening MRI following my talk. So stay tuned. This is the Delaware notification text. As you can see, administration shall provide to each patient a notice containing the results of the mammogram, including information about the patient's breast density. And it says the notice shall include a statement that a report of the results has been sent to the patient's physician, and the patient should discuss the report, including the findings regarding breast density, with her physician. Lastly, I'd like to speak to you about racial disparity in breast cancer. Breast cancer has a disproportionately devastating impact on minorities. This is a mortality graph, and in the pink over here we have Black women, and in the darker pink over here we have white women. And as you can see, and this is the same graph as I showed earlier from 1975 to 2015, but stratified in races. And you can see Black women do have a downward slope, same as white women, but the disparity, or the difference in mortality, is quite high, 41% higher in Black women than in white women. It is thought this is in part due to lower rate of African American women participating in breast cancer screening, but unfortunately, it is also due to the higher and more advanced or more aggressive type of cancer that disproportionately affects Black women. These are the triple negative tumors, and also, these women have a higher risk of BRCA1 and BRCA2 genetic mutation. So I'm just going to show you, these are recently has made headlines. Delaware worst in nation for triple negative breast cancer. Delaware #1 in aggressive form of breast cancer. So unfortunately, we need to we need to make sure that all women, especially Black women, do receive screening mammograms starting at age 40. Okay, here we go. All right. It is encouraged, in summary, it is encouraged we identify women at risk by assessing risk factors beginning at the age of 30. Identify women who meet NCCN criteria so that they can undergo genetic testing. All women are at substantial risk for breast cancer, and stratifying the risk can help in selecting those patients that may benefit from supplemental screening. And if the patient has dense breast tissue, they will receive a state-mandated notification letter encouraging a conversation with their referring physician about supplemental screening. And let's remember, Black women are 41% more likely to die from breast cancer, so we can encourage them to get their screening mammogram yearly beginning at age 40. With that note, I thank you for your attention.